Hi, my name is Brianne Cryer and this is my patient Carrie. Today I'm going to be demonstrating a hand and forearm clinical examination. This will include a thorough patient history to find out if it's an acute or chronic condition. And if it's a traumatic situation, you'll want to know the date of the injury, how the injury occurred, and what position the hand was in when the injury occurred. If it's a non-traumatic injury, you will want to know if it's an acute or chronic condition, what the date of onset was, if the symptoms are getting worse over time, whether there were situations that make the problems worse or better over time, and what functional effects will be related to the injury. For any situation, you will want to know any treatments the patient has sought out and up until now. And looking at the nervous system, we will want to know whether there is any pain, which can be shooting, sharp, or dull, and any tingling in the forearm and hand. So you'll look at the vascular system, checking for any color changes and making comparisons to each arm to see if there is any stiffness or swelling. Check capillary refill by adding pressure to the pad of the finger or fingernail just enough to blanch the surface, and when you release the pressure, there should be a return of pink color on the surface in about 2 seconds. So if I have Carrie's hand here, I'll pinch the finger, and then she has good capillary refill. We also want to look at the range of motion by making sure the patient can touch their thumb to their shoulder on the ipsilateral arm. Carrie, can you do that? Good. Okay. With the elbows tucked in, they should be able to pronate and supinate the wrists. Good. With the elbows on the table, the patient should be able to flex and extend the wrist down. Flex and then extend. Good. Another way to do that and check for symmetry is by having them bring their hands in like this and then go all the way down. Good. And you want to just check to make sure everything's in alignment. So you can also have them place each dorsal surface of the hand together like this and check for symmetry again. Thank you, Carrie. Okay. Next, with the elbows on the table, have the patient flex and extend the fingers. Good. When they close the fist, you want to make sure they touch the distal palmar crease here. Good. Okay. You also want to make sure that the thumb can touch the metacarpal head of the little finger. Good. Okay. When checking for tendinitis of the elbow, wrist, and hand, you want to isolate the tendons that are problematic. For a very common situation like lateral epicondylitis, there will be pain in the lateral epicondyle when performing a manual muscle test on the extensor muscles. Okay, we've drawn the muscles here on the arms. In the extensor compartments here, we have the extensor muscles. These are the superficial extensor muscles. So here's the brachioradialis here, the extensor radialis longus here, extensor radialis brevis here, extensor digitorum, extensor digiti minimi, and then extensor carpi ulnaris here. Okay, and then on the deep layer of the extensor aspect, you have supinator here, abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus, and extensor indicis here. And then we also have the carpals here. Okay, and then on the flexor compartments of the forearm, we have superficial here and deep here. So we have brachioradialis here, then pronator teres, flexor carpi radialis, flexor digitorum superficialis here, and then flexor carpi ulnaris along here. And then in the deep layer, we have, again, flexor digitorum profundus, flexor pollicis longus, and then pronator quadratus here. Okay, so when checking for tendonitis of the elbow, wrist, and hand, you want to isolate the tendons that are problematic. For a very common situation like lateral epicondylitis or tennis elbow, there will be pain in the lateral epicondyle when performing a MMT on the extensor mechanism. For medial epicondylitis or golfer's elbow, there will be pain in the medial epicondyle when performing MMT on the flexor and pronator teres. In the wrist, there are 6 compartments of the extensor retinaculum. Abductor pollicis longus and extensor pollicis brevis are in the first compartment here. The wrist extensors, extensor carpi radialis brevis and longus, are in the second compartment. Extensor pollicis longus is in the third compartment, and extensor digitorum and extensor indicis are in the fourth compartment. Extensor digiti minimi is in the fifth, and extensor carpi ulnaris is in the sixth. Any of these tendons can become inflamed, and most common is inflammation of the first compartment here, which is called de Quervain's syndrome. A positive response for Finkelstein's test will diagnose this syndrome. To perform the Finkelstein's test, you would have the patient flex the thumb and bend your fingers and ulnarly deviate the wrist while you palpate. If there is pain, the test is positive. Occupations that are commonly associated with this diagnosis would be golfing, racketing, mail sorting, and filing. There is also intersection syndrome, which is a diagnosis of inflammation and pain in the intersection between the first and second compartments here, which is about 6 centimeters proximal to the radial styloid. To test, you would have the patient extend and radially deviate the wrist. There you go. You will palpate the intersection while manual muscle testing, and a painful response would be positive for intersection syndrome. Repetitive wrist motions are associated with this diagnosis. Weightlifters, rowers, canoers may have this problem. Patients with radial-sided tendonitis can also have triggering when they flex the thumb or fingers. The tendons might catch or pop on them. Patients with digital triggering often have pain or a nodule along the flexor tendons at the level of the A1 pulley proximal to the metacarpal phalangeal joints. You will palpate at the A1 pulley level and flex the digits. A positive response would be painful. you should be able to feel the popping or catching in that area. When examining the wrist for flexor carpi ulnaris and flexor carpi radialis tendinitis, resistive wrist flexion and radial and ulnar deviation while palpating the tendon will also elicit a painful response. The flexor carpi radialis longus tendon runs radial to palmaris longus, right here. Palpation and resistance to that area would elicit pain. Flexor carpi ulnaris would be tested by ulnarly deviating the wrist and applying resistance. Patients can also have piezotriquetral arthritis. The flexor carpi ulnaris tendon runs on the pisiform bone. Here. And the patient may have pain with resisted ulnar deviation and flexion while palpating on the pisiform. Grinding the pisiform into the triquetral bone, and this would elicit pain. Less common tendinopathies might include tendinitis of extensor pollicis longus tendon, which is in the third compartment and runs around the Lister's tubercle, which is on the radius. Resisted thumb extension while palpating on Lister's tubercle would be painful. You can also check for tendinitis of the finger extensors by having the patient extend their fingers and palpating the area of the fourth compartment where extensor digitorum runs through. It would be painful. There can be tendinitis with extensor carpi ulnaris tendon where it can slip over the ulnar head, causing pain and instability. To check for this, you would want to supinate the forearm and extend the wrist and ulnarly deviate the wrist with resistance while palpating along the extensor carpi ulnaris tendon. This may elicit some pain. You may even feel the tendon slipping over the ulnar head. The carpal bones in the wrist may have instability and ligamentous problems at the lunate triquetral joint, lunate scaphoid joint. From Lister's tubercle on the radius, a centimeter distal and laterally would be the scaphoid bone. The lunate and the triquetral bone. Beneath that is the pisiform bone. Putting a finger on the pisiform bone and one thumb on the triquetral and your other thumb on the lunate bone allows you to rub these bones against each other, and that would elicit pain. Scaphoid fractures are common. Put your thumb up like this. The scaphoid bone is at the bottom of the anatomical snuff box, and it would be a place to palpate to see if there is instability or pain. that might indicate a scaphoid fracture. Along the anterior portion of the forearm, we have the carpal tunnel that is covered by the flexor retinaculum. The finger flexors and long flexor of the thumb make a total of 9 tendons. The median nerve also runs through the carpal tunnel. There can be problems within the median nerve. This region right here, you can perform a Tendon's test and a compression test with flexion of the wrist. This may elicit pain or tingling of the fingertips and the medial nerve distribution. These tests can also be used to test ulnar nerve compression in the Guyon's canal here. For wrist instability, a Watson's scaphoid shift test would be used for scaphoid instability. You can use your thumb to push in dorsally on the scaphoid tubercle. You might feel a pop or jolting when doing so. That may indicate a scaphoid lunate abnormality. What also may indicate a mid-carpal or lunotriquetral instability would be a Littman test or the Ketch or Clump test. Deviating the wrist back and forth, you may feel a clump. Cubital tunnel syndrome may also be an issue with the ulnar nerve. It comes around the medial epicondyle in the area of the cubital tunnel. Pain may be elicited with flexion of the elbow or with a Tendon's test on the cubital tunnel. Patients will complain of numbness on the dorsal aspect of the area innervated by the ulnar nerve. If the compression of the ulnar nerve is at the elbow, but it's at the wrist, then there is already a branching of the ulnar nerve, so sensitivity of this aspect will be intact. There may be sensation issues on the volar aspect of the hand. Patients with carpal tunnel syndrome may also have involvement of the thenar muscles and some intrinsic muscle problems and may not be able to cross their fingers or do thumb adduction. A positive Frohman sign is indicated when the thumb IP joint flexes to hold an object in place. Okay. When you try to pull it away, secondary to intrinsic muscle weakness. A positive Wardenberg sign is done by observation by examining if the little finger is unable to abduct to the ring finger. Carpal tunnel may affect opposition of the thumb and little finger. The thenar muscles that may have atrophy or be soft when opposition is taking place. There is also carpometacarpal arthritis of the thumb. One can do a grind test where you are grinding the thumb metacarpal into the trapezium, and that would cause pain. There is also gamekeeper's thumb test that examines ulnar collateral ligament involvement. You would support the metacarpal and then deviate the thumb back and forth to check the status of the ligament to see if there is any laxity. Some manual muscle testing of the fingers can take place. Finger flexors include flexor digitorum superficialis with its 4 muscle bellies coming in through the carpal tunnel to insert on the middle phalanges, flexing the proximal IP joints. Deep to this is flexor digitorum profundus with its 4 tendons inserting on the distal phalanges. That would flex the distal IP joint. These can be tested by having the patient flex the finger up to check the status of the FDS tendon. Flex this finger. To isolate the FDP tendon, you could hold the finger like so and ask the patient to flex the tip of the finger. Radial nerve palsy is a condition also called wrist drop, when the radial nerve supply extensor muscles are no longer functioning. To test this, you would want to isolate the flexor digitorum muscles. You can do this by having the patient flex the fingers and extend at the MCP joint. You may want to make sure the patient can extend the wrist and that the thumb can cross over onto the index finger when on a flat surface. With ulnar nerve palsy, you will see a claw hand. There is hyperextension of the MP joint and flexion of the IP joint. Boutonniere's deformity is a flexion or neutral MP joint and flexion of the PIP joint, but an extension of the DIP joint. Swan neck deformity is where there is hyperextension of the PIP joint and flexion of the DIP joint. Boutonniere's deformity occurs when the central slip of the extensor digitorum is injured at the middle phalanx. The lateral bands lose their connection to the central bands, so they drift more anteriorly towards the PIP joint, causing that joint to flex. The position of the lateral band of the distal phalanx remains intact, but because of the flexed position of the PIP, the lateral bands are now more posterior to the axis of motion of the DIP joint, so that joint becomes hyperextended. The swan neck deformity occurs primarily with arthritis and subsequent weakness of the intrinsic muscles. So the PIP joints can deform into hyperextension, and then again the distal DIP joint is flexed. When examining patients for suspected finger fractures, we would look at the nail plane. If the finger is twisted or out of plane, there would be a rotational deformity and indicate a proximal fracture and dislocation on the axis. You can see all the metacarpal heads in alignment when she makes a fist. To test for sensation, you can use the 2-point discrimination test using a paper clip spaced 5 millimeters apart to see if the patient can discriminate between 1 or 2 points with their eyes occluded. This can be performed statically or dynamically. Normal is a less distance than 8 millimeters. That can concludes some of the testing that can be done for a hand evaluation. Thank you, Carrie.
Thanks, Bree.